Good morning. My name is Gwynne Kirchen. I'm the program director for the Pain Medicine Fellowship at the Medical College of Wisconsin. I'm so excited to be able to tell you more about our program as you prepare for our interview day. I have been a faculty member here for about 7 years. I've been the program director here for about 4 years or so, and I'm excited to tell you more all about us. Our pain medicine program, like many programs you're going to interview with, we pride ourselves on our multidisciplinary approach to pain, utilizing multimodal techniques, particularly interventional management of chronic pain complaints. We are not only leaders in our institution in the ambulatory practice of pain, but also on our inpatient pain service as well. We're affiliated with a major academic center in Milwaukee, Wisconsin, where we see very complex patients, and we provide care through the spectrum of inpatient to outpatient, additionally in many clinical sites, surgery centers, hospitals, clinic, doing clinic visits or consultations, and also interventional techniques at all of those locations. As an overview, we take 4 fellows per year. This expanded in 2016 from a cohort of 3 to a cohort of 4. We have no set quota on how many internal candidates or from particular backgrounds that we want to have in our program. We like to have balance and fellows from a variety of backgrounds just to improve the learning opportunities for our fellows. Some changes in recent years. We've had a few new faculty join us over the last 2 academic years. Dr. Kappas and Dr. Surik joined us in 2022. They have an anesthesiology and PM&R background, respectively. And then Dr. Daha is our newest faculty to join us. He trained at Rush and worked in private practice in Texas for a few years and joined our practice in December of 2023. This has increased the clinical opportunities for our learners, and we're very excited about the addition of these wonderful faculty and educators. About 2 years ago, we shifted our fellow allocation. For many years, we had 2 fellows at a time at a VA site and 2 at MCW sites. And now we have 1 fellow at VA sites and 3 at MCW sites at any given day. It's not that 1 fellow is assigned to the VA for the entirety of the year. Our fellows rotate nearly every week to a new clinical site. And like I said, at any given week, there's 1 at a VA site and 3 at MCW sites. Having 3 learners at MCW sites gives us more flexibility in where our fellows are assigned. We are allowed to have more robust multidisciplinary experiences, and this has allowed us to create electives and additional time with our colleagues in interventional radiology, spasticity, and neurosurgery so that you can see a variety of procedures. And our fellows also are allotted then 1 week to rotate in a private practice location in town with one of our very busy, very productive, very wonderful alumni, Dr. Christina Moore at Advocate Aurora. She's their medical director here in the Midwest. And so this allows our fellows to spend time with her as well, because this flexibility allowed us to create more electives. Additionally, this was based off of feedback that our fellows desired more time at MCW sites, given the greater breadth and complexity of the patients that we were treating for, particularly with interventional techniques. So in summary, as we've kind of alluded to, you, as I said, you spend about 75% of your academic year at an MCW-based location. Most of that time is at the TOSA Health Center, but also at some other community site locations, including Orthopedic Sports and Spine, West Bend, and Drexel. I'll show you these places on a map. You'll spend a week or 2 on rotation on the regional and inpatient pain service during your residence or during your fellowship. And some of your multidisciplinary experiences will be at clinics located at the Froedtert Hospital itself. About 25% of your year is at the VA Medical Center, where you'll spend time mostly at their pain clinic, and some of your multidisciplinary experiences will be there as well. And on occasion, you will visit our pediatric pain clinic at Children's Hospital. So here's a map to kind of help make sense of where we are located. So Wauwatosa here is a suburb to the west of Milwaukee, so about 15 minutes from downtown Milwaukee. And that's where Froedtert and Children's Hospital is located. Frederick is our main hospital system. Our TOSA Health Clinic, where we spend the majority of our outpatient time, is very nearby, just a couple minutes away. And then the VA also about 10 minutes away, just to give you an idea about the distance and the time between your main clinical sites. And I've also mentioned that there are a variety of community sites that our faculty work at and our learners go to as well. I mentioned a location in West Bend, that's our northernmost location. Orthopedic Sports and Spine, that is located in Menominee Falls. And then Drexel Health Town Center is down here in Oak Creek, which is our southernmost location. There is a ambulatory clinic located at Mequon. We currently don't have any faculty that go there. I don't anticipate that that will be happening in the next academic year, and I don't anticipate that our fellows will be going there anytime in the next year or two, but there is a clinic building there where we could go in the future if and when we expand. So the Medical College of Wisconsin Pain Management Division, where the group that you'll spend 75% of your time with, is comprised of Dr. Kappas, Daha, Diarra, and Jerizi, who's the medical director, Kirchen, myself, the program director, and Dr. Surik. We also have a pain psychologist, Dr. Trost, and a PA, Sarah Ramirez. And this is our main clinical group treating patients within the Medical College of Wisconsin and the Frederick Health System, where we provide consultative clinic visits and do pain procedures for our patients. The TOSA Health Center is our most centrally located clinical practice. This is where the majority of your time will be spent at MCW. This is also where the majority of our other learners are located, including medical students and residents. And we have a clinic-based procedural suite here where we do interventions. We just added an RFA machine here this last year to just have more locations where we can offer radiofrequency ablations to our patients, whereas most of them are done at the surgery center. This is what our learner workroom looks like. So this is where our residents and fellows sit during the day. Nice corner office with big windows, so that's very nice. And then this is our interventional procedural suite. Here, this is what most of the rooms kind of look like at many of our sites. You've got a C-arm with the display monitors, your fluoro table, your cart of drugs. And that's where we do our procedures at the TOSA location. There are other community sites such as West Bend Health Center, where Dr. Daha works, Drexel Town Square, where Dr. Diarra works, and Orthopedic Sports and Spine, where Dr. Kappas, Indrizi, and myself rotate, where you will help take care of patients as well. This is the procedural suites and the center at Oak Creek, or the Drexel Health Center. The procedural suite, the recovery room. Up to the top right, you see the physician work office. That's Dr. Donahue, one of our prior fellows, sitting there working. And then down below, where the nurses and oftentimes physicians may sit during the workday as well. And you see some of the ultrasound machines that we have in clinic for clinic-based procedures. This is pictures of what our Orthopedic Sports and Spine Center looks like. The physicians typically sit here in this back left office to the left of all of these pictures. And here in the middle, sometimes our learners will sit there, MAs and nurses. And then, of course, it's flanked by clinic rooms. And here's a picture of what one of the clinic rooms looks like. Just to try to approximate for you all a tour that we would do if we were all together in person. And as you see, it probably looks a lot like the clinical and interventional suites that you're used to at your own institution. You'll also spend 1/4 of your year at the VA Medical Center working with the faculty, Dr. Liang, Shankar, and Tegalakis. Dr. Tegalakis is the medical director. There are, I believe, currently 2 APPs that work in that clinic as well. There are 2 fluoro procedural suites in the pain clinic. Dr. Shankar is a world renowned for his ultrasound knowledge and skill, and does a fair amount of ultrasound guided procedures. One of the unique things about this clinic is not only do they have a large catchment area in southeastern Wisconsin and Wisconsin itself, but really throughout the Midwest, since it is one of the most advanced VA pain clinics in the Midwest. One of the other things that I think is an advantage of having some time training at a VA medical center is you get exposure to procedures that may not be covered in your region by insurance companies or Medicare. For example, here in the Midwest, in our LCD, Pulsed RFA and lateral branch RFA are not covered benefits, but we can provide that at the VA. And so our learners do get exposure to that skill in case the coverage changes in the future. And this is something you do want to provide your patients. It is nice to get that experience. And so that is unique in our training program that you can get that since we do have time with our VA pain clinic. That's a picture of the VA hospital or medical center, and the VA pain clinic is embedded within the medical center. This is a picture of the fellow and resident workroom. So you see a conference room in the middle and then workstations kind of flanking around the walls. This from the bottom is a view from the windows of the fellow and resident workroom, and that is the Brewers Stadium, which you can see is very nearby the VA Medical Center, and that is the view of what you are seeing from the pain clinic window. So nice big windows with a really nice view. Again, this is their largest procedural suite, looks a lot like the others. Kind of the basic things that you're going to find in a procedural suite. This is their larger one. They have a second one that is slightly smaller. You'll spend some time at the Froedtert Hospital. You'll spend 1 to 2 weeks on a regional anesthesia rotation with getting exposure in regional anesthetic techniques. You'll also spend time with our inpatient pain service, typically 1 to 2 weeks, which is combined time between the regional and the inpatient pain service. Our inpatient pain service, we do perform inpatient pain procedures such as epidurals or joint injections. That team is supported by our full-time nurse practitioner, Lisa, and at least one anesthesiology resident is assigned kind of full-time to that service at a time. There is some weekend and overnight call coverage expectations of the fellows, and we'll discuss that later on in the presentation here. You'll spend time at Children's Hospital on our pediatric pain rotation. This is another opportunity that I think is quite unique to our institution and training program, that we have such a robust pediatric pain clinic and experience available for you. They truly provide pain consultation in a multidisciplinary, multimodal fashion. The pain physician sees patients with their families and a pain psychologist or social worker all simultaneously. It is a really interesting experience to see patients in this way. Some other things to point out: they have a very active research department, and we do have a fellowship slot for anesthesiologists who are interested in a pediatric pain fellowship, where you spend 2 years in total training. And in the end, you are pediatric anesthesia trained, pain trained, with a focus on pursuing a career in pediatric pain management. If that's of interest to you, feel free to reach out for further details. We also have a robust pain psychology division at the Medical College of Wisconsin, led by our medical director, Dr. Trost, who you are likely meeting with here today. We have rotating graduate students. We have a therapist, social worker, Ross, who provides care to our patients as well. We offer individual cognitive behavioral therapy. We run a group therapy program called Pain School. We provide biofeedback as well for our patients, either with the psychologist, social worker, or our grad students, and have a variety of ongoing research trials within the pain psychology division. You will spend time with those experts, kind of learning about how they help take care of our patients. And there are other multidisciplinary experiences that you will get to pursue while you are here. And we kind of formulate what is best in your experience over the year based on what specialty you come from. So for example, if you come from a PM&R background, perhaps spending another half day in PM&R clinic has diminishing value for you. And instead, we'll have you spend some time in our pre-op anesthesia clinic or working on airway skills and IV skills. And for anesthesiologists or those coming from other backgrounds, like emergency medicine or family medicine, maybe spending time in the EMG clinic is valuable. So we kind of adjust this to what you are looking to get out of your education and what you want to do in your career. So options available are time with physical medicine, PM&R, neuroradiology, spasticity, neurology with a focus on interventions for headaches, physical therapy, EMG, a required rotation on hospice, pre-op anesthesia rotation, and opportunities to go to interventional radiology, neurosurgery, and the private practice rotation that I discussed earlier in the slide set. We perform roughly 200 procedures per month on the Medical College of Wisconsin side of things, seeing about 200 patients per month throughout the system as well. Fellows are involved in nearly all of the procedures. They don't see every one of our clinic visits. Some of our faculty are seeing clinic visits independently. Sometimes they are seeing them with medical students or residents, but nearly every procedure does have a fellow in attendance to kind of get that learning opportunity. It makes for a busy but very manageable clinical practice that I think allows you to get the volume you need to graduate competent, comfortable, and efficient, but not feel overwhelmed, overburdened, or too rushed during the workday. We average 30 to 40 trials of spinal cord stimulation or DRG in combination throughout an academic year. We have an uptrending volume over the last quarter, which hopefully we will sustain going forward. It's always a bit of balance and work in referral generation, and we are seeing an uptick in our volumes in the last quarter. Implants are done by the pain faculty or neurosurgical faculty, and you are allowed to scrub in and participate in the implants regardless of which faculty is implanting them. The VA reports an average about 200 to 250 procedures per month, and this is whether it's in clinic or fluoro or ultrasound. The numbers stated above from the Medical College of Wisconsin are more considering procedures that are fluoroscopic or ultrasound guided in an interventional suite. And the VA averages about 10 spinal cord stimulator trials or implants in combination through the year. This is dependent a lot on the fellows generating that clinical practice as they are excited and interested and want to provide this to the patients. And so that average is about 10 per year. Some years that number is higher. In regard to neuromodulation, we do predominantly dorsal column stimulation, but we also do DRG stimulation. We perform all the trials in the health system, and then implants are done by our team or our functional neurosurgical team. We do use all devices that are available on the market, but probably a predominance of Medtronic and Nevro in our clinical practice. We just got the Sprint peripheral nerve system approved in our health system in the last month or so, so I anticipate a growing volume of that by the time that you arrive. What are some of our changes in our interventional practices? We developed and began a new de novo intrathecal pump program in 2019. We run this at this is a very selective program. We probably have about 10 intrathecal pumps in our program, doing about 2 per year or so. So there is some exposure to see if that's something you'd be interested in doing in your future practice. Peripheral nerve stimulant had been approved or had been used on occasion in our clinical practice. We obtained full system approval just in the last month or so, so I anticipate that that volume will grow. As a large academic institution, one thing that we have found to be very frustrating is that we are not particularly agile in approving new therapies. It can take a year or so to bring them to our clinical practice to get the full approval and purchasing done. We anticipate full approval and launching of our mild program in the year of 2024 as well. That paperwork was started just a bit after the PNS system, so I anticipate that that should be coming through in the near future as well, and we'll be providing that to our patients very soon. Academic productivity, our fellows are required to participate in some type of academic project, but that is up to each individual fellow to decide what they'd like that to be. It could be a QI project, it could be a poster at a conference, it could be a full IRB approved research project. Most choose either a QI project or a poster at a conference. If you do get accepted, there's often some departmental assistance and funding to help you attend a meeting if your poster is accepted for presentation. Our fellows have gone to ASRA, AAPM, APS is now defunct, but they did go to that at times. NANS and other meetings as well. They have obtained scholarships through ASRA and NANS to attend and to do particular cadaver training. Some have gone to the MARC as well. This is a group of learners and faculty at ASRA from a few years ago. Here is a picture of a learner at NANS from a few years ago as well, presenting a poster that we did together. And our faculty or our residents I should say our fellows graduate very successfully and go on to great opportunities. We received an award from AAPM for an excellent fellowship program in 2016. Our fellows are performing well on the in-training exam, averaging the 70th percentile. Last year, we had a 100% board pass rate, and we have a very strong history of job placement. Our fellows are well recruited and well received on the job market because of the robust, clinically focused training that they get during their time here in our fellowship. I like to say from here, go anywhere. We have a great reputation in Wisconsin and the Midwest, and many of our fellow graduates stay in this region and get great jobs, but we also succeed every year in helping with job placement elsewhere throughout the country, mostly hospital employed and private practice, but also in some academic roles as well. So that kind of covers our clinical program. I'm going to shift into talking a little bit about our didactic program, of which I am very exceedingly proud, and I think is something that makes us stand out amongst our peers of fellowship programs. Our didactic consists of a variety of learning strategies listed here on the screen. When you first look at this, it can be a bit overwhelming. I'm going to explain how we try to do this purposefully and broken up into small pieces so that it doesn't overwhelm your week. And then we'll kind of revisit this in summary at the end. So for example, as I said, we try to not have this be overwhelming. You can anticipate 1 to 2 educational activities on your calendar per week. We feel like if it gets to be too much more than that, then it can be a bit too overwhelming. So typically we'll have lectures on Tuesdays, and if we're going to do something as a full group with faculty, either M&M or Journal Club, we do that on Wednesdays. And if it's a week that we have a gathering on Wednesday for Journal Club or M&M, then we usually cancel that Tuesday meeting of lectures, again, to try to reach that goal of only 1 or 2 educational didactic sessions in a week. So the didactic program starts out in the summer with what we call our boot camp. And this is really just the kickoff to fellowship, where we're trying to teach you some of the basics that you need as you transition into your career as a pain medicine expert. We focus on basic procedures, basic pharmacology, and basic pain pathologies. This runs for about the first 6 weeks or so of fellowship with 2 lectures per week. Again, focus on the basics, getting you up, ready, and kicked off to start your academic year. After we finish the boot camp series, we transition into our more traditional multidisciplinary lectures. Boot camps are a mix of in-person and virtual, a little bit more in-person, and our multidisciplinary lectures are more virtual. These are about 50% from faculty within the pain division, for example, talking about opioids, billing, neuromodulation, anticoagulation, and safety, and about 50% from other faculty within the Institution of the Medical College of Wisconsin about adjacent and relevant topics. So for example, like rheumatology lecture comes from one of the rheumatologists, or we have great relationships with palliative, neurology, radiology, PM&R, addiction, that provide lectures about these topics that are part of the scope of our practice and important for you to know. We run a Journal Club series. We gather 8 times in the academic year, so each fellow is responsible for presenting 2 articles throughout the year. This is supported by our Journal Club director, Dr. Singh, and each fellow has a faculty mentor as well who can help you with putting together this discussion. This is also typically virtual. This is not particularly high stress. We like to review a recent article, either about a medication or other treatment strategy or intervention, and talk through and see what we think of it and how it could apply to our clinical practice. Once a month, we pull out our fellows for an academic half day. This has a very much of a board review type focus, where we do board style question reviews. We review the most recent chapters that everybody has read in our shared textbook, have a nice lunch together. It's nice because this is a learning session where you are relieved from clinical duties. So like on a Wednesday afternoon or a Friday afternoon, you may leave clinic at noon and then you come and do this. It's a nice opportunity. We gather as a group. I usually lead about 50% of these, and it's nice to just kind of touch base, see how things are going, have some dedicated time together in person and review some topics, prepare for boards, and then additionally, we'll do one faculty-led kind of learning opportunity at each of these sessions. We may review suturing or interventional safety guidelines, or I do a workshop on intrathecal pump management, but it's a nice opportunity for us to do a little bit of a longer learning session together. And this is, like I said, is once a month. We'll also rely on some of our industry colleagues to allow for some particular hands-on training opportunities. For example, we have reps come in for Botox for migraines and lead a session. Here's pictures of our fellows doing some simulation for the mild procedure. We've done simulation for cooled RFA and suturing. So here in the top left is our suturing. The top right, this is our Botox for migraines. The bottom right, we are doing a cooled RF session. And on the left side, we're actually doing a arts in medicine session together. So kind of learning in a variety of different ways. This is just a picture of our group gathering near graduation. This was in 2020 or 21. It was a year that we didn't have a full formal graduation because of COVID. And so we all just went out to dinner together. So some of our learners and faculty members. We also have a very impressive simulation program. We have a few different sites that have full high fidelity sim centers. This is pictures of our sim center that we have at Froedtert Health, where we do now most of our simulation. We often do this in a multidisciplinary form where our nursing team, MA team, or others who are involved in the interventional care of our patients will join you for a simulation session. We are doing scenarios of rare but catastrophic complications of interventional pain management, so that, hopefully none of us will ever have a seizure in our patients with a cervical stellate block, but at least it won't be the first time that you've ever seen it if it does happen, because we'll live through that in the simulator. We run a PBLD flipped classroom series for our residents, and our fellows are the faculty for these. So this happens once a week on Thursdays. We have 4 cases with full answer keys that the fellows lead with the residents. This kind of serves multiple purposes. The fellows get experience as educators, which is important in your growth towards independence and is an ACGME requirement. And we also cover the topics that are important for our anesthesiology residents to succeed in their advanced exam. So this is topics on low back and leg pain, widespread pain, CRPS, and cancer pain. The residents are provided these cases ahead of time. They are meant to be prepared, and then they come in ready to discuss, and our fellow service faculty mentors to the discussion with the answer key. I mentioned that we have a guided reading assignment, so we all use the same textbook with assigned chapters throughout the year. Everyone is reading 1 chapter a week. All fellows sign up for 1/4 of the chapters, and when it is the week of one of your chapters, you have the responsibility to generate a 1-page study guide and share it with your classmates. Thereby, at the end of the year, you have all created a great board review kind of book based off the textbook that you read. The hope is that you'll use these 1-page study guides for more engaged active learning while you read these chapters, mark up the study guide, mark up the textbook, be a bit more engaged. Because I don't know if you're anything like me, sometimes if I sit down and read a chapter from a textbook, I get to the end and I'm like, I did not retain any of that. So the goal of this is that we have more engaged reading to retain that information, both for your growth of the knowledge you need as a pain doctor and for success on the board exams. For our anesthesiology trained fellows, we have a wonderful board preparation series. There's one component where you just learn the strategy of the oral board stem, and then we have a variety of OSCE practice scenarios with standardized patients, reviewing regional and TEE that really helps our fellows prepare and succeed on the anesthesiology oral boards. At times we have other didactic components. We'll occasionally have a challenging spine case conference. It's intended to be virtually monthly. I would say it probably occurs once a quarter, where we talk about challenging cases between the pain faculty and neurosurgery faculty. About 3 times a year, that multidisciplinary lecture series, we host a researcher from within the institution just to come in and share the research that they are doing in their lab so that you can be aware, but some of the cutting edge stuff going on in pain medicine research and at your institution. We also have a professionalism series, which we share across the anesthesiology fellowships. So we share that with the cardiac and the ICU and the OB fellowships, et cetera. And this covers topics required within professionalism by the ACGME throughout the year, such as second victim and other topics about professionalism. So what does a typical workday look like? This is kind of now bringing together the clinical practice and the didactic practice, which we have covered. So your typical workday, patients are often scheduled from 8 to 4 p.m. So you'll probably arrive a little bit before that, around 7:30, and you're going to leave around 4 or 4:30. About 1 to 2 days a week, we will have educational activities. These are most often virtual and in the morning, so typically from 7 to 8 a.m. So if you have a 7 o'clock education session, you're going to arrive to your clinical site 6:55, settle down, turn on your computer, join in the virtual session. And when that session wraps up, you're going to go and participate in patient care for the rest of the day. On occasion, there will be evening educational sessions. These are more often the ones that we're sharing throughout the anesthesiology fellowship programs, like the Anesthesia Board Review Prep and the Professionalism Series. You will typically cover 1 week and 1 weekend of call in the month. So let's talk about what that looks like. You are covering pretty much what you are mostly covering is our inpatient pain service. As I mentioned, during the weekday, there is a resident, an NP, and a faculty. They are the ones responsible for the care of the inpatient patients during the workday. At 5 p.m., they sign out to the night float anesthesia resident. The night float anesthesia resident is the first point of contact if a new consult comes in or a clinical question comes up. If they cannot address it based off of the sign out or their clinical knowledge, they will then at that time reach out to the fellow, which would be you. And then of course, you're also backed up by the faculty member, which is the faculty member who was on the CHIP service that day. So they should know the patients quite well. This typically is not a significant amount of work. On average, my fellows tell me that they get contacted maybe twice in sleeping hours in the entire academic year for these types of issues. We do not order medications. We are not ordering the PCA, ordering the pain medications. That is done by the primary team. We provide consultative recommendations. The one caveat is if we are running an advanced infusion like ketamine or lidocaine, we do order that and manage that. On weekends and holidays, the fellow and faculty round on the patient census during daytime hours. That varies a little bit based on how many patients there is and what faculty is on service. You can anticipate working maybe 2 to 4 hours in the hospital seeing the patient list. Most of the time, we just leave when rounding is done. I'm typically done by around 11 and we leave the hospital. The fellow covers the pager for new consults or for any questions that come up during the daytime hours. Again, at 5 p.m., now the fellow will sign out to the night float team, and now that resident becomes the first point of contact, and you are back up to them. So it works out pretty well. It is not an overwhelming amount of clinical responsibility. We see a lot of interesting, challenging cases. There is a lot of learning that occurs on the service. And it is, I think, a strength that you get this exposure. More and more health systems are looking, growing, and developing expectations that their pain physicians provide this type of consultative recommendation as more and more patients have chronic pain, use disorder, chronic opioid tolerance, and are admitted to the hospital and need assistance with their management. And this is a really good opportunity to get that experience. All right, let's talk about benefits. The Medical College of Wisconsin pays quite well, particularly considering the cost of living. So now next year's salary is around $80,000 a year. Really good insurance as a fellow, reasonable cost of living. Most trainees live in Wauwatosa, which is kind of the little suburb where most of our clinical sites are. Some people prefer to live in downtown Milwaukee, about 15 minutes away if they want more of that downtown life. Otherwise, you can live in some of the nearby suburbs, 10 minutes away or so if you want just a little bit more square footage or a yard or something like that. Milwaukee is a really nice city to live in. I'm sorry that now that we do everything virtually, you don't get the opportunity to come tour. If you haven't been to Milwaukee before, you might not have ever thought about it too much. But we are a lovely city, particularly in the spring, summer, and fall. We have a lot going on with professional sports team, music, theater, outdoor activities, and quite good food. And we're within about an hour of Chicago. So if you do want a slightly bigger city experience, you can go to Chicago as well, either by train or by car. And the cost of living and the pay is such that you're going to have a lot more expendable income if you come to the Medical College of Wisconsin than if you perhaps are training in Chicago itself. A lot of great restaurants, festivals, beer gardens, breweries, fine dining, custard, ice cream, great food. I love to eat. I love to go out to eat. So if this is anything you're interested in, I am happy to talk with you kind of endlessly. A lot of professional or semi-pro sports. We are home to the Milwaukee Brewers and Milwaukee Bucks. The Green Bay Packers are about an hour and a half away or so. And then we have some lower tier sports as the Milwaukee Admirals, which is hockey, and the Milwaukee Wave, which is indoor soccer. So there's usually always some sort of sporting activity that you can see in any given week. This last year, one of our fellow kind of social activities was we went to a Milwaukee Bucks game, and that was a lot of fun. Also, arts and other entertainment, ballet, art museum, theaters. Summerfest is the largest music festival, and that is hosted at the fairgrounds in downtown Milwaukee on the lake. That's usually in early July. We have State Fair in early August. A lot of fun things going on, particularly in the summer. A lot of outdoor opportunities and things to do. Boat cruises, stuff at this. We have a really nice zoo, state parks, great places to hike, canoe. Whether you are looking to do that yourself or you have a family and want to know what activities there are, we would love to talk with you more about this in your interview or when you meet with our fellows. They can tell you more about Milwaukee and Wisconsin as well. We'll talk about this more on the interview day, but just to be prepared, you're probably going to have about 4 interviews. One will be with me, about 2 will be with one of our other faculty members, and 1 will likely be with our pain psychologist, Dr. Trost. Our psychology colleagues have been part of our interview committee for over a decade. They truly are a part of our team in the care of our patients, in the education of our learners, and in the interview process. And this just really, I hope, reflects to you that when we say we are multidisciplinary, we really mean that. They are a part of our team. Sarah Pritchard is our coordinator. I'm sure you've gotten many emails from her. She's a great point of contact if there are any tech issues. You'll also have a session where you'll meet with 2 of our fellows. We have 2 PM&R fellows and 2 anesthesiology fellows this year. They show up they schedule themselves. They all do an equal amount of these interview days. So you'll meet with 2 of those to just ask some more of the questions that will help you as you decide where you want to train. And when you're done with your last interview for the day, you're done. You can take off. Thank you for spending your time in preparation for interview day, learning more about our program. We're really proud of the education and clinical program that we have here at the Medical College of Wisconsin, and we hope that you will really seriously consider joining us for training in preparation for your pain career. Thank you all.